पैंक्रियाज की पैथोलॉजी आज डिस्कस करेंगे। चैप्टर 17 है मीडियम रॉबिन्स का। हेलो एवरीवन एंड वेलकम बैक टू माय चैनल। दिस इज प्रोफेसर आसिफ कुरैशी एंड यू आर वाचिंग डॉक्टर आसिफ लेक्चर्स। पैंक्रियाज की पैथोलॉजी को 3 पार्ट्स में डिवाइड किया है इन्होंने। द फर्स्ट वन इज द कॉन्जेनाइटल एनॉमलीज, यानी जो बाय बर्थ प्रेजेंट होंगी, डेवलपमेंटल इश्यूज हैं। द अदर वन इज द इन्फ्लेमेशन ऑफ पैंक्रियाज एंड देन द लास्ट वन इज द पैंक्रियाटिक न्यूप्लाज्म। सो ऑल वेरी इंपॉर्टेंट बिकॉज आई मीन पैंक्रियाटिक न्यूप्लाज्म्स की अगर बात करें सो दे आर लाइफ थ्रेटनिंग। रीजन उसका ये है बिकॉज ये काफी लेट डायग्नोज होते हैं। अगेन उसका रीजन ये है क्योंकि पैंक्रियाज इज वन ऑफ द वेरी डीप स्ट्रक्चर्स और इससे एसोसिएटेड जो सिम्टम्स हैं दे अपीयर वेरी वेरी लेट। देयरफॉर पेशेंट्स जब क्लिनिक्स में प्रेजेंट करता है तो उस वक्त तक इसका स्टेज और ग्रेड काफी एडवांस हो चुका होता है। देयरफॉर दीज आर लीथल कैंसर। सो पैंक्रियाटिक कैंसर्स डिस्कस करेंगे इस चैप्टर में। ऑल्सो पैंक्रियाटाइटिस, आई मीन पैंक्रियाटाइटिस कैन ऑल्सो बी अ लाइफ थ्रेटनिंग कंडीशन। सो विल टॉक अबाउट दिस। ओके, सो लेट्स फर्स्ट बिगिन विद द कॉन्जेनाइटल एनॉमलीज। लेकिन उससे भी पहले एक जेनेरिक बात जो हमें करनी है, पैंक्रियाज इज a transversely oriented retroperitoneal organ extending from the so-called C loop of the duodenum to the hilum of the spleen. So इसकी जो लोकेशन होती है, so this is the duodenum for example, तो ये C loop of duodenum है, second part of duodenum। यहाँ से ये pancreas it goes all the way और ये पीछे जाकर इसकी जो टेल है वो स्प्लीन पे टच कर रही होती है। So that is the extent। ट्रांसफर्स पड़ा होता है एंड रीट्रोपेरिटोनियल है, सो पेरिटोनियम के पीछे है, ठीक है। ऑल्दो द पैंक्रियाज डज नॉट हैव वेल डिफाइंड एनाटॉमिक सबडिविजन्स, वेल ये जुमला इतना भी ठीक नहीं है क्योंकि गो वॉच माय एनाटॉमी लेक्चर्स फ्रॉम बीडी चौरासिया। इनफैक्ट मैंने पैंक्रियाज की एनाटॉमी, उसकी हिस्टोलॉजी, उसकी डेवलपमेंट सब ऑलरेडी अपलोड किया हुआ है। लिंक्स दे देता हूँ, तो जाकर मेरे चैनल पे प्लेलिस्ट देख लीजिएगा ताकि आपको पैंक्रियाज की एनाटॉमी अच्छे से पता हो। पैंक्रियाज इज रियली 2 ऑर्गन्स पैकेज इनटू 1, दैट्स एन इंपॉर्टेंट पॉइंट। इसकी डेवलपमेंट भी ऐसी होती है। सो डॉर्सल बर्ड, वेंट्रल बर्ड, 2 अलग अलग समझे ऑर्गन्स बनते हैं, फिर वो आपस में मिक्स हो जाते हैं, मिल जाते हैं। और जब एक दफ़ा एक ऑर्गन बन जाता है उसके बाद भी उसमें एक्चुअली 2 ऑर्गन्स हैं। सो वन ऑर्गन इज एक्सोक्राइन पोर्शन, द अदर वन इज द एंडोक्राइन पोर्शन। द आइलेट ऑफ लैंगरहैन is scattered in the pancreas serve as the endocrine function, and the exocrine portion is the one that makes the bulk of the tissue, and it is the major source for enzymes which are essential for digestion. So if you look at the pancreas, in the pancreas there are nest of cells and these cells are called islet of Langerhans. These behave like endocrine tissue and the job is to produce very important stuff called insulin which is involved in the metabolism of carbohydrate. बाकी जो ज़्यादा चंक है वो अपनी सिक्रीशन एक डक्ट में डालते हैं which is the pancreatic duct which enters into the duodenum. उसके बारे में भी पढ़ेंगे भी। सो बेसिकली एक के अंदर 2 डिफरेंट तरह के ऑर्गन, एंडोक्राइन पोर्शन भी है और एक्सोक्राइन पोर्शन भी है। एक्सोक्राइन पोर्शन से डाइजेस्टिव एंजाइम्स बन रहे हैं और एंडोक्राइन पोर्शन से इंसुलिन बन रहा है। सो डिजीजेस अफेक्टिंग द पैंक्रियाज कैन बी सोर्स ऑफ सिग्निफिकेंट मॉर्बिडिटी एंड मोर्टेलिटी। सो इट्स अ वेरी वेरी इंपॉर्टेंट। डायबिटीज तो आपको पता ही है ना कितना प्रेवलेंट है। एंड यू नो इंडिया, पाकिस्तान, दीज आर अमंग्स द टॉप कंट्रीज जहां डायबिटीज का इंसिडेंस और प्रेवलेंस बहुत तेजी से बढ़ रहा है। इनफैक्ट पाकिस्तान तो अब नंबर 1 पे जा चुका है in terms of the disease burden of diabetes. So pancreas ही associated है ना। Unfortunately the retroperitoneal location of the pancreas and the generally vague nature of signs and symptoms associated with its injury or dysfunction of the exocrine portion allow many pancreatic diseases to progress undiagnosed फॉर एक्सटेंडेड पीरियड्स ऑफ टाइम। अब ये बड़ा इंपॉर्टेंट है। मैंने आपसे कहा ना कि कैंसर भी पैंक्रियाज का काफ़ी लेट प्रेजेंट करता है। इट प्रेजेंट्स वेरी वेरी लेट। उसकी लोकेशन ऐसी है डीप डाउन और फिर उसके आसपास स्ट्रक्चर्स ऐसे हैं कि जब सिम्टम्स डेवलप होते हैं। सो फॉर एग्जांपल वन ऑफ द कॉमन सिम्टम फॉर पैंक्रियाटिक कैंसर इज जॉन्डिस। तो होता ही है कि जो पैंक्रियाटिक डक्ट है वो बाइल डक्ट के साथ मिलकर यहाँ एंटर होती है, तो बाइल डक्ट ऊपर जा रही है, ऑब्वियसली गॉल ब्लैडर, लिवर। तो अगर पैंक्रियाटिक हेड का कैंसर है तो ये बाइल डक्ट भी ऑब्स्ट्रक्ट होती है, तो ऑब्स्ट्रक्टिव जॉन्डिस डेवलप होता है, लेकिन ये काफी लेट डेवलप होता है। यानी अगर पैंक्रियाटिक कैंसर की वजह से पेशेंट ऑब्स्ट्रक्टिव जॉन्डिस डेवलप करके आ रहा है तो इसका मतलब ये है कि कैंसर ऑलरेडी बहुत एडवांस हो चुका है। सो इट कम्स, दीज पेशेंट्स कम वेरी लेट इन द क्लिनिक। तो जब तक वो पहुंचते हैं डिजीज एक्चुअली काफी प्रोग्रेस कर चुकी भी होती है। द पैंक्रियाज गेट्स इट्स नेम फ्रॉम द ग्रीक वर्ड पैंक्रियास which means all flesh, is a complex lobulated organ. The endocrine portion is only 1 to 2% of the pancreas, but it is composed of millions of cells in the clusters which are called islets of Langerhans, and they secrete a very important thing, insulin, also the glucagon and also the somatostatin. Insulin is the hero because it is very important for glucose metabolism, and deficiency of insulin leads to diabetes mellitus. इसीलिए ये सबको इंसुलिन का नाम याद रहता है। हालांकि इसमें से ग्लूकागॉन जो कि भी बहुत इंपॉर्टेंट है और सोमेटोस्टैटिन भी रिलीज होता है। फिर जो एक्सोक्राइन पोर्शन है पैंक्रियाज का वो ग्लैंड की तरह है, उसमें एसिनर सेल्स हैं एंड देन देयर इज अ डक्ट। तो जो ग्लैंड्स हैं दे प्रोड्यूस डाइजेस्टिव एंजाइम्स और डक्ट के जरिए वो सारे डाइजेस्टिव एंजाइम्स डिओडेनम तक पहुंचते हैं एंड दे हेल्प इन द प्रोसेस ऑफ डाइजेशन ऑफ प्रोटीन, लिपिड्स एज वेल एज कार्बोहाइड्रेट्स। सो आपकी जो डाइटरी कंपोनेंट्स हैं जो आप खाना खा रहे हैं वो तब तक डाइजेस्ट नहीं होंगे जब तक पैंक्रियाज के ये एंजाइम्स डिओडेनम तक नहीं पहुंचेंगे। Okay, then the epithelial cell lining of the ducts are also active participant in the pancreatic secretion. The cuboidal cells that line the smaller ductules secrete bicarbonate rich fluid, while the columnar cells which line the large ducts produce the mucin. So pancreas से जो ducts आ रही हैं आसपास pancreatic tissue है, उन ducts की बात हो रही है कि bicarbonate rich fluid निकल रहा है और mucus rich fluid निकल रहा है। The epithelial cells of the ducts also express a very important protein which is known as CFTR protein, the cystic fibrosis transmembrane conductance regulator. Aberrant function of this protein affects the biochemical constituents of the secretion अगर ये protein mutated होती है, and this is where you know this disease known as cystic fibrosis. Cystic fibrosis में the expression of CFTR is disturbed और इसकी expression disturb होने की वजह से जो composition of the pancreatic secretion है that is disturbed, and there is thick mucus plug formed and pancreatitis associated. So that's an important anomaly that you should remember. As discussed later, autodigestion of the pancreas can be catastrophic event. देखें, pancreas is a bag full of different enzymes, and if there is for any reason leakage and secretion of enzyme into the pancreatic tissue, it will lead to pancreatitis, and this pancreatitis can also lead to autolysis of pancreas, autodigestion of pancreas, and that can be life threatening. Okay, a majority of pancreatic enzymes are synthesized inactive in the form of proenzymes, and these proenzymes are then activated. We also have trypsin inhibitors also secreted by the acinar ductal cell. So this is kind of a protective mechanism pancreas में trypsin के डैमेज को रोकने के लिए. Trypsin cleaves and inactivates itself, a negative feedback mechanism that normally puts a limit on the local activated trypsin, and acinar cells are remarkably resistant to the action of activated enzymes such as. So यहाँ पे ये जो सारी बात कर रहे हैं, the point is कि pancreas में जितने भी enzymes हैं, they have the capacity to destroy the pancreas. तो nature ने कुछ ना कुछ protective mechanism pancreas को दे रखा है जिसमें उसकी protection है from the dangerous effects of the enzyme. Such as एक ये सेफ्टी है कि ज़्यादातर जो एंजाइम्स हैं वो इस प्रो एंजाइम रिलीज होते हैं, दे आर इनएक्टिव. फिर कुछ उनके एक्शन को काउंटर करने के लिए प्रोटीन्स हैं सच एज स्पिंक1. देन जो सेल का आर्किटेक्चर है वो किसी हद तक रेजिस्टेंट है उन एंजाइम्स के एक्शन के साथ. तो एंड दैट्स इंपॉर्टेंट बिकॉज दीज एंजाइम्स कैन डैमेज द पैंक्रियाज इटसेल्फ completely. Diseases of the exocrine pancreas include cystic fibrosis, which is the problem in the CFTR gene, उसमें mutation. There are congenital anomalies, acute and chronic pancreatitis, and neoplasms. Cystic fibrosis will be dealt with जहाँ हम दूसरे genetic disorders करेंगे, और बाकी की जो चीज़ें हैं congenital anomalies, inflammation and tumors that we will discuss in this chapter. We are not going to hit endocrine pancreas at the moment because that we will do when we are doing the metabolism effect. Metabolism की जब हम pathologies कर रहे होंगे तब ये हम diabetes mellitus को discuss करेंगे. इस वक्त the topic of discussion is largely exocrine pancreas. So the first disease set जो हमको discuss करना है include the congenital anomalies. अब ये जो congenital anomalies हैं they are associated basically with the developmental problems obviously. तो आपको पहला तो काम ये करना है कि you must understand the embryology of pancreas development, कि pancreas develop कैसे होता है. तो मेरी लैंगमैन की पूरी सीरीज पड़ी हुई है, वहाँ you should watch those videos ताकि आपको clearly पता हो कि how pancreas is developed. क्योंकि काफ़ी सारी जो congenital anomaly है उसका जो concept है वो pancreas की development से समझ में आएगा. And process of pancreatic development is a complex process involving fusion of a dorsal and a ventral bird, and subtle variation in this process frequently give rise to congenital variation and pancreatic anatomy. In pancreatic anatomy, while most of these do not cause clinical diseases, variants can present challenges to the endoscopist and surgeons. For example, failure to recognize the idiosyncratic anatomy could result in inadvertent severing of a pancreatic duct during surgery. So ये सारा discussion का point ये है बाज़ कॉन्जेनाइटल एनॉमलीज इस तरह इंपॉर्टेंट होती हैं कि दे प्रेजेंट विद इंपॉर्टेंट सीवियर सिम्टम्स एंड you know about those anomalies and you have to correct them. Pancreas is not one of them. Usually if the patient has an anomaly of pancreas, congenital anomaly, तो वो usually इतना serious नहीं होता, उसके symptoms present नहीं करते, but ये important फिर भी है. तो इसकी जो कॉन्जेनाइटल एनॉमलीज पेंक्रियाज की हैं उनकी इंपॉर्टेंस उनकी सिवियरिटी ऑफ सिम्टम्स से एसोसिएटेड नहीं है. इनकी इंपॉर्टेंस एसोसिएटेड है कि अगर किसी और वजह से पेशेंट की लेप्रोटमी हो रही है या एंडोस्कोपी हो रही है या लेप्रोस्कोपी हो रही है, सो कोई और सर्जरी हो रही है एंड यू आर प्लेइंग इन द एरिया ऑफ पैंक्रियाज. सो व्हेन आई से यू आर प्लेइंग इन द एरिया ऑफ पैंक्रियाज, सो आई मीन कि गॉल ब्लैडर है या बाइल डक्ट है या डियोडेनम है, इस एरिया में आप कोई सर्जरी कर रहे हैं एंड यू डोंट नो अबाउट द एन्युलर पैंक्रियाज, तो व्हाट यू विल डू इज यू विल damage the structures which you did not anticipate. तो आपको पता होना चाहिए कि pancreatic anomalies किस किस तरह की हैं ताकि सर्जरी में कोई इशू ना हो. Okay, so agenesis, that's a rare disorder and that is incompatible with life. That's the bottom line. अगर pancreas बनेगा ही नहीं, agenesis means pancreas बन ही नहीं रहा, it's totally absent. So if this is what happens, there is no life because pancreas is required for life. ठीक है. Pancreatic duodenal or homeobox 1 PDX1 is a domain transcription factor critical for normal pancreatic development, and if this is mutated, pancreas does not develop, and if pancreas does not develop, there is no life. Okay, so simple, but this is one of the rare form of pancreatic disorders. Okay, then pancreas divism. Pancreas divism is the most common congenital anomaly of the pancreas. So that one is the most common, with an incidence of 3% to 10%. In most individuals, the main pancreatic duct joins the common bile duct. So stories किस तरह से होती है कि suppose ये पूरा pancreas है तो ये इसकी center में pancreatic duct है, it binds with the common bile duct. और फिर वो एंटर होते हैं एक साथ into the duodenum. So the main pancreatic duct joins the common bile duct which is coming from the gallbladder just proximal to the papilla of Vater, and the accessory pancreatic duct drains into the duodenum through a separate papilla. So there are two ducts entering. There is one major duct which combines with the bile duct and they enter into the duodenum combined together, but there is another pancreatic duct entering. It is known as the accessory pancreatic duct or the duct of Santorini that drains into the duodenum through a separate papilla. Pancreas divism is caused by a failure of fusion of the fetal duct system of dorsal and ventral pancreatic primordia. As a result होता ये है कि the bulk of the pancreas drains into the duodenum through the minor papilla. अब ये बात हो गई उल्टी, यानी नॉर्मल सर्कमस्टांसिस में अगर डॉर्सल वेंट्रल पैंक्रियाटिक बग ठीक से मिले हैं, सो जो मेन पैंक्रियाटिक डक्ट है, जो मेन पैंक्रियाटिक डक्ट उसका दूसरा नाम है विरसंग, द डक्ट ऑफ विरसंग. सो डक्ट ऑफ विरसंग इज द मेन ड्रेनेज चैनल. लेकिन अगर इसमें कोई इशू है तो मेन ड्रेनेज चैनल जो है वो ये छोटा वाला माइनर पैपिला बन जाता है, एंड द अदर डक्ट इज देन द मेन डक्ट. द डक्ट ऑफ विरसंग इज इंडिविजुअल विद डायविज्म ड्रेन्स ओनली अ स्मॉल पोर्शन. नॉर्मल पर्सन में डक्ट ऑफ विरसंग इज द मेन डक्ट, लेकिन अब द डक्ट ऑफ संटोरिनी इज द मेन डक्ट. तो रिवर्स हो गई कहानी. ठीक है. मोर देन 95% ऑफ द इंडिविजुअल्स आर एक्चुअली एसिम्प्टोमेटिक क्योंकि इससे कोई उनको मेजर मसला नहीं होता. हाउएवर सम मे डेवलप pancreatitis possibly related to inadequate drainage of the pancreas secretions. अब सोचें ना यार कि एक there was a minor duct, इसका काम था हल्का फुल्का छोटा छोटा कम लिक्विड लेके यहाँ डालना. अब सारा मेजर फ्लो इधर आ गया, फ्लो तो सारा इधर आ गया लेकिन रोड तो ये छोटा है ना. इसको ऐसे समझो कि एक आपके घर की तरफ जा रहा है मेन रोड. ठीक है. सो देयर इज वन मेन रोड गोइंग टुवर्ड्स योर होम. दिस इज योर ब्यूटीफुल होम. अब ये मेन रोड गवर्नमेंट ने किसी काम करने की वजह से ब्लॉक कर रखा है और यहाँ पे कोई ना कोई कंस्ट्रक्शन वर्क चल रहा है. एक आपके घर की तरफ जाता है सर्विस रोड. ये सर्विस रोड छोटा है लेकिन इस वक्त खुला है. अब सारा ट्रैफिक जो आपके मेन रोड पे चल रहा था अब वो डाइवर्ट हो जाएगा इस छोटे से सर्विस रोड पे. तो ये चौक तो होगा ना, यहाँ पे मसला तो होगा, पीछे ट्रैफिक बनेगा क्योंकि बड़ा रोड बंद हो गया. और जब बड़ा रोड बंद हो जाएगा तो छोटे रूट से इतना सारा ट्रैफिक गुजरेगा तो बैक फ्लो होगा ट्रैफिक का. अब इंजाइम सोचो, इंजाइम बड़ी डक्ट से निकल जाते थे यानी बड़े रोड से निकल जाते थे, कोई मसला नहीं होता था. अब वो छोटे रोड से जा रहे हैं तो बैक फ्लो होगा और बैक फ्लो होगा तो वो इन्फ्लेमेशन कॉज कर सकता है. सो दिस पैंक्रियाटिक डायविज्म कैन समटाइम्स cause pancreatitis. It can lead to pancreatitis. Okay. Another congenital anomaly is the annular pancreas. It is relatively uncommon variant of pancreatic fusion in which a ring of pancreatic tissue completely circles the duodenum. It can manifest with signs and symptoms of duodenal obstruction such as gastric distension or vomiting. So usually ये duodenum है, duodenum के इस तरफ उसके C cup में पूरा pancreas होता है, but sometime अगर dorsal और ventral bud ठीक से fuse करके rotation नहीं हुई तो ये पूरा duodenum को circle की form में पकड़ के रखता है और इसे हम कहते हैं annular pancreas. इससे duodenum obstruct हो सकती है. Obviously ये duodenum को पूरा compress करता है. Then ectopic pregnancy की तरह ये word है ectopic pancreas. Ectopic का मतलब होता है कि अपनी normal location से कहीं और होगा. So the normal location जहाँ भी है उसके अलावा कहीं पाया जाएगा. So aberrantly situated or ectopic pancreatic tissue occurs in about 2% of the population. Favorite site are stomach में, duodenum, jejunum, Meckel's diverticulum and ileum. These are the common sites जहाँ पे pancreatic tissue हो सकता है in case of ectopic pancreas. These embryologic rests typically are small and are located in the submucosa of stomach या intestine जहाँ भी वो है. They are composed of normal pancreatic acini and occasional islets of Langerhans as well. Though usually incidental and asymptomatic, ectopic pancreas may become inflamed, leading to pain. अच्छा ये pain काफ़ी atypical होगा. You would not be suspecting pancreatitis because वो duodenum में होगा या किधर और you'll be thinking about pancreas. So इसकी चूँकि location different है, so that can confuse the clinician. Approximately 2% of the pancreatic neuroendocrine tumors arise in these ectopic. So इसकी एक importance ये भी है कि ये सिर्फ inflame नहीं होते ectopic tissues, but they can also develop tumors, neuroendocrine tumors, which are actually not very bad tumors to have. I mean, prognosis good if surgically removed. Okay. Now the congenital cysts. Congenital cyst जैसे किडनी में होती है, किडनी में polycystic disease, there are cyst formation, problem in the connective tissue and ultimately leading to cyst formation. ऐसे congenital cyst pancreas में भी reported है. In polycystic disease, for example, kidneys, liver and pancreas, they all contain small cysts. Congenital cysts are generally unilocular and range from microscopic 5 centimeter in diameter. बड़ी भी हो सकती हैं वैसे बाय द वे और बहुत ही छोटी भी हो सकती हैं. दैट्स व्हाट दे आर सेइंग कि माइक्रोस्कोपिक से लेके 5 सेंटीमीटर तक बड़ी भी हो सकती हैं. दे आर लाइंड बाय आइदर यूनिफॉर्म क्यूबाइडल और फ्लैटेंड एपिथेलियम एंड आर इनक्लोज्ड इन अ थिन फाइब्रस कैप्सूल. दैट्स व्हाट अ स्ट्रक्चर ऑफ सिस्ट इज कि बाकायदा एक एपिथेलियल लाइनिंग है, कैप्सूल है. These benign cysts contain clear serous fluid, an important point of distinction from pancreatic cystic neoplasm, which are obviously most of the times mucinous. So if it's a clear fluid filled cyst, it is benign. अगर वो mucinous है, mucus उसमें plug की तरह कुछ dark thick material है, then you think about malignancy. So these are all the congenital problems associated with pancreas. Okay, so we talked about agenesis, complete absence, then pancreas divism, or annular pancreas, ectopic pancreas, and then congenital cyst. So that completes the discussion on congenital anomalies. अब मुझे बात करनी है inflammation of pancreas, which is very very important because clinically common भी है और इसके outcomes भी life threatening तक हो सकते हैं. So let's talk about pancreatitis. Literal sense में अगर बात करें तो pancreatitis basically means inflammation of pancreas, and this is true for any other inflammation as you know. अगर skin की inflammation है तो dermatitis, इसी itis is always indicating inflammation. It can be of acute nature and therefore called acute pancreatitis, and acute pancreatitis basically means कि function can return to normal if the underlying cause is taken away. So that is an acute nature. It becomes okay if the underlying cause is removed. And then there is a chronic pancreatitis, which is long term और इसकी complications different हैं. So दोनों पढ़ेंगे one by one. Let's first start our discussion on the acute pancreatitis. It is obviously a reversible condition, inflammatory disorder of the pancreas that varies in severity from focal edema and fat necrosis to widespread hemorrhagic necrosis. And this is where it becomes very, very life-threatening as well. This is a relatively common condition with an annual incidence of 10 to 20 per 100,000 people. So that is not uncommon. That's actually pretty common. The most common cause of acute pancreatitis, at least in the US, is impaction of the gallstones within the common bile duct, impeding the flow of the pancreatic enzymes through the ampulla of Vater, and this is also sometimes called gallstone pancreatitis. This is closely followed by pancreatitis secondary to excessive alcohol intake. Now, ये जरा समझ लें, आपको एनाटमी पता है ना, एनाटमी ऐसे है कि दिस इज द पैंक्रियाटिक डक्ट एंड हियर वी हैव द कॉमन बाइल डक्ट, और वो ये दोनों मिलकर फिर जा रहे हैं और एंटर हो रहे हैं इनटू द डियोडेनम, ऐसे ही है। अब अगर देयर इज अ गॉल ब्लैडर स्टोन एंड इट स्लिप्स डाउन हियर, और वो यहाँ आके ब्लॉक कर देता है, तो व्हाट विल हैपन कि जो पैंक्रियाटिक एंजाइम्स हैं उनका फ्लो नहीं होगा एंड देयर विल बी बैक फ्लो एंड लीकेज ऑफ पैंक्रियाटिक एंजाइम्स। एंड आई जस्ट टोल्ड यू इन अ व्हाइल अगो कि जो पैंक्रियाटिक एंजाइम्स हैं, दीज एंजाइम्स आर डेंजरस एंजाइम्स, दे कैन ऑटो डाइजेस्ट द पैंक्रियास, they can cause harm to the pancreas, and if there is impaction of gallstone, for example, there is backflow of pancreatic enzymes and therefore acute pancreatitis. तो बेसिकली किसी भी वजह से अगर ब्लॉकेज है कॉमन बाइल डक्ट का या इस कंबाइंड डक्ट का जो डियोडेनम में एंटर हो रही है, दैट विल लीड टू बैकफ्लो ऑफ पैंक्रियाटिक एंजाइम्स, सो ब्लॉकेज विल लीड टू एक्यूट पैंक्रेटाइटिस। एंड देन अल्कोहल इज second most common cause. Overall, gallstones and alcoholism account for more than 80% of the cases of pancreatitis, and there are some other causes as well जो भी इस टेबल में हम डिस्कस करते हैं। These include non-gallstone related obstruction. Such obstruction can be seen in pancreatic cancer, for example, or it can be seen in pancreatic divism, जो भी हमने थोड़ी देर पहले डिस्कस किया था, biliary sludge, ascaris की प्रेजेंस में, chronorchis sinensis। अब ये तमाम कंडीशन किसी भी वजह से अगर इस एरिया में ब्लॉकेज है तो देयर विल बी, नाउ दिस ब्लॉकेज कैन बी बिकॉज ऑफ द पैरासाइट, इट कैन बी बिकॉज ऑफ pancreas का हेड का कैंसर, it can be because of any thick secretion accumulating here, such as which happens in pancreatic divism, which is actually the most common pancreatic anomaly. तो किसी भी वजह से अगर इस पॉइंट पर obstruction है तो there will be backflow and acute pancreatitis. So वो स्टोन की वजह से नहीं है, they are non-gallstone जितने भी यहाँ पे causes लिखे हैं. Some drugs can cause it, particularly anticonvulsants, cancer chemotherapeutic agents, thiazide diuretics, estrogens. They are very, very commonly used clinical drugs and they can lead to pancreatitis. Infections can cause it, such as mump virus, Coxsackie virus. They can also affect directly the exocrine portion and cause inflammation. Some metabolic disorders, such as hypertriglyceridemia, more triglyceride levels, hyperparathyroidism. So you have to remember all these conditions. Also hypercalcemic states. So if you divide the etiologic factors of acute pancreatitis, they can be, classified into all these things. They can be infectious, mumps and Coxsackie, vascular shock, atherombolism, polyarthritis nodosa, mechanical, this is the most common cause, gallstones, trauma, iatrogenic, mutations in SPINK1 gene that will also lead to, protector कम हो जाएगा। प्रोटेक्टर कौन था? ट्रिप्सिन इनहिबिटर। सो ट्रिप्सिन इनहिबिटर कम हो जाएगा, और अगर ट्रिप्सिन इनहिबिटर कम हो गया तो ट्रिप्सिन ज्यादा डैमेज करेगा पैंक्रियास को। Alcoholism, hyper, so ये सब मैंने भी ऊपर आपको बताया। That's an important table to remember if you want to remember the causes of pancreatitis. Ischemia can also cause pancreatitis, particularly because of vascular thrombosis. अगर blood supply of the pancreas में thrombus है, then ischemia and then pancreatitis. Trauma can cause it. Endoscopy particularly, this would be iatrogenic, यानी आप कोई मेडिकल डायग्नोस्टिक या कोई थेराप्यूटिक प्रोसीजर कर रहे थे और उसकी वजह से pancreatitis हो गया। There can also be other germline mutations which can lead to pancreatitis, such as अभी मैंने एक आपको यहाँ पे जीन बताई, एक तो PRSS1 और दूसरा SPINK1. SPINK1 particularly very important because it leads to, trypsin से प्रोटेक्टर जीन है, ये बेसिकली ट्रिप्सिन इनहिबिटर है। सो अगर ये म्यूटेटेड है, दैट कैन ऑल्सो लीड टू पैंक्रेटाइटिस। सोचे ना, ट्रिप्सिन, मैंने आपसे बार बार कह रहा हूँ कि दीज आर वेरी हैवी टाइप्स ऑफ एंजाइम्स, इफ लेफ्ट एक्टिव तो ये पूरे पैंक्रियाज में तबाही मचा सकते हैं। तो इसको कंट्रोल करने के लिए SPINK1 का प्रोडक्ट होता है, अगर यही म्यूटेटेड है तो इसको कंट्रोल करने वाला कोई नहीं है। सो द चांसेस ऑफ पैंक्रेटाइटिस विल ऑब्वियसली इंक्रीज। Of note, 10 to 20% of the cases of acute pancreatitis have no identifiable cause. So there is a small percentage which we label as idiopathic, कि हो रहा है pancreatitis हमें पता ही नहीं है। Although the growing body of evidence suggests that many may have an underlying genetic basis which is yet not identified, but कोई ना कोई genetic cause तो होगी। Pathogenesis क्या है जनाब? Acute pancreatitis appears to be caused by auto-digestion of pancreas by inappropriately activated pancreatic enzymes. Basically outflow का obstruction है और backflow है enzymes का। Now these enzymes cause auto-digestion. That's the main pathogenesis of acute pancreatitis. ठीक है? Now premature activation of the trypsin within the substance of the pancreas can unleash these pro-enzyme and they become now very dangerous. Okay? Trypsin also convert pre-kallikrein to its activated form, thus sparking the kinase system, and therefore it activates the whole, coagulation pathway leads to complement system activation and a lot of inflammation. 3 pathways can incite the initial enzyme activation that may lead to acute pancreatitis. One is obstruction of the pancreatic duct because of any reason. It can be because of gallstones, it can be because of pancreatic tumor, it can be because of any sort of duct obstruction. So impaction of the gallstone or biliary sludge or extrinsic compression, such as in the case of carcinoma, there will be pancreatitis, or lipases is secreted in an active form. Local fat necrosis may result because lipase will be there. Injured tissues, periacinar myofibroblasts and leukocytes then release pro-inflammatory cytokines and the inflammation worsens. Okay. Then we have primary acinar cell injury. This pathogenic mechanism comes into play in acute pancreatitis caused by ischemia, viral infections, drugs, and direct trauma to the pancreas. So directly acinar cell injury by all these agents. Then defective intracellular transport proenzyme within the acinar cells. In normal acinar cells, the digestive enzymes intended for zymogen granules and hydrolytic enzymes destined for lysosomes are transported in discrete pathways after synthesis and in the endoplasm. So that's the normal route. However, at least in some animal models of metabolic injury, pancreatic proenzymes and lysosomal hydrolases become pegged together. This results in proenzyme activation, lysosomal rupture, and local release of the activated enzymes, and it will obviously cause pancreatitis. So either there is duct obstruction, तो नॉर्मल जो मैकेनिक्स हैं वो डिस्टर्ब हो गए, या डायरेक्ट एसिनार इन्वॉल्वमेंट है, या जो एंजाइम्स बन रहे थे प्रो एंजाइम्स और फिर उनकी एक्टिवेशन विद इन द मशीनरी ऑफ द सेल, उसमें कोई ना कोई डिस्टर्बेंस है जिसकी वजह से एंजाइम्स लीक होकर पैंक्रियास को डैमेज कर रहे हैं. सो दीज आर द 3 बेसिक मैकेनिज्म्स बाय व्हिच पैंक्रेटाइटिस एक्चुअली हैपन. Alcohol consumption may also cause pancreatitis by a range of different mechanisms. Alcohol transiently increases the pancreatic exocrine secretion, and because of this increase in secretion, the chances of mishandling and inflammation increase. Alcohol also has direct toxic effect on the acinar cells of the exocrine pancreas. Finally, the chronic alcohol ingestion results in secretion of protein-rich pancreatic fluid, which leads to deposition of inspissated protein plugs. So, alcohol की वजह से there is pancreas का जो fluid है that is high protein content, और high protein content का मतलब ये है there will be plugs formed, और वो plug बनेंगे तो duct obstruct होगी. So alcohol can cause this as well. So these are some mechanisms by which alcohol leads to pancreatitis. Okay. Right. Let's moving forward. What are the clinical features of acute pancreatitis? Abdominal pain is the key feature, is the most common feature presenting to the clinics. Its severity varies from mild and uncomfortable feeling to a very, very severe pain, maybe incapacitating. So patient comes to you with like heavy epigastric pain and it radiates straight to the back. Whenever you have such a patient in the emergency room, you straight away go for the levels of amylase and also lipase. If amylase levels are very, very high, you make the diagnosis of acute pancreatitis. So abdominal pain is the main feature. Then if there is a patient with full-blown acute pancreatitis, that basically is a medical emergency of first order. Affected individuals usually experience sudden calamitous onset of acute abdomen with pain, guarding, so all the signs of acute abdomen, and characteristically the pain is constant, intense, referred to the upper back, and all these are heavily diagnosed as they are all pointing very heavily towards acute pancreatitis. The manifestation of the severe acute pancreatitis are attributable to systemic release of digestive enzyme. Now that is serious. अगर local inflammation है सिर्फ pancreas की, तब तक तो मामला फिर pancreas तक है, लेकिन अगर it goes out into the circulation, that will lead to a systemic inflammatory response. The initial clinical evaluation may be, include severe leukocytosis, raised WBC count, DIC, which is disseminated intravascular coagulation, acute respiratory distress syndrome. So things are getting serious there, okay? Alveolar damage. So that's systemic shock developing. Peripheral vascular collapse shock is developing, and hypovolemia, patient ka blood pressure will be down, and patient is entering into a shock situation. Laboratory findings include markedly elevated levels of serum amylase during the first 24 hours, followed by rising serum lipase levels. If the patient is late, 72 to 96 hours of pain onset, go for the lipase level. Amylase are not then very much helping. Hypocalcemia can result from precipitation of calcium in areas of fat necrosis because there are lipases released from the pancreas. These lipases will lead to fat necrosis. Calcium will be consumed in the process of saponification, and the patient may have symptoms of hypocalcemia, tetany, for example, irregular cardiac rhythms, for example. The enlarged inflamed pancreas can be visualized by a CT or MRI. The crux of the management of the acute pancreatitis is by and large supportive treatment. For example, if the patient is developing shock, you treat the blood pressure. If the patient has to go NPO, nil per oral, and be on IV fluids most of the time. So even total restriction even of the oral food as well as the fluids, it has to be only IV fluids. Okay, why? Because if you are giving the patient fluids, the pancreas will be stimulated by gastric secretions, and we don't want the pancreas to be stimulated now. We want to shut off the pancreas. Although most individuals with acute pancreatitis eventually recover, some 5% may die if it is not treated, particularly on the emergency basis. इसीलिए मैंने यहाँ पे एक बात आपको बताई थी कि this is an acute medical emergency of first order. You have to take actions very, very rapidly. In surviving patients, the complication, the sequelae include sterile or infected pancreatic abscess or pancreatic pseudocyst. So pancreatic abscess and pancreatic pseudocyst, these are two very common complications after the episode of pancreatitis has gone away. So pancreatic pseudocyst क्या चीज़ है जनाब? Abscess तो obviously inflammation के बाद का सारा जो कचरा बच गया, that is the pancreatic abscess. Pseudocyst is a sequelae of acute pancreatitis where around the pancreas a cyst is formed. Liquefied area of necrotic pancreatic tissue is there. It becomes walled off by fibrous tissue to form a cystic space, lacking an epithelial lining. So there is no epithelial lining in the cyst, therefore it is called a pseudocyst. और ये basically inflammation की तबाही के बाद के खंडरात हैं. The cyst contents are rich in pancreatic enzymes, and a laboratory assessment of the cyst, aspiration, needle डाल के aspirate करते हैं उस liquid को, it will tell you कि उसके अंदर lipase and all these things will be very, very high, pancreatic enzymes. Pseudocysts account for approximately 75% of all the pancreatic cysts. While many pseudocysts spontaneously resolve, they can become secondarily infected, and large pseudocysts can compress and even perforate. So these can be serious complications of acute pancreatitis. Okay, now we have to talk about chronic pancreatitis. Chronic pancreatitis is characterized by long-standing inflammation. So this is not an acute event. Obviously, it is a long-standing event. That's why it is called chronic pancreatitis. And that leads to irreversible destruction. That is the bottom line. In acute pancreatitis, remember I told you it is a reversible issue. Here it is an irreversible damage of the exocrine pancreas, and ultimately the islets of Langerhans are also lost. Of note, and then ultimately what you will have is like no exocrine pancreas working, so digestive enzymes will not be there, and if islets are not working, then there will be no insulin, so you are metabolically very much screwed. Of note, recurrent bouts of acute pancreatitis regardless of the etiology can ultimately lead to chronic. So ये तो general हमारी body में principle भी है कि acute inflammation leads to chronic inflammation in many scenarios. हमेशा ऐसा नहीं होता, ज़रूरी नहीं है कि ऐसे ही हो, but this is one of the possibility. By far the most common cause of chronic pancreatitis is long-term alcohol abuse. और होता ये है कि जब आप alcohol ले रहे होते हैं, वो भी not recommended amounts में and very frequently, it leads to small acute attacks of pancreatitis very frequently, which cumulatively then leads to chronic pancreatitis. Middle-aged men constitute the bulk of the patient with the chronic pancreatitis. Less common causes of chronic pancreatitis include the following: duct obstruction. इससे usually acute pancreatitis होता है, not chronic, but this is less common. Tropical pancreatitis is a poorly characterized heterogeneous disorder seen in Africa and Asia, but इसके cause actually पता नहीं है. People think that there are some hereditary bases with these races, but we don't know. Hereditary pancreatitis, SPINK1 mutation particularly, for example, also ये भी पहले acute का attack होगा pancreatitis का, फिर chronic. Chronic pancreatitis associated with CFTR mutation in patients with cystic fibrosis. So होता ये cystic fibrosis के patient में कि there are, because this particular protein is not working properly, so there is thick discharge of the secretions from the pancreas, and there are plaque formation, and that leads to pancreatitis. अगर ये continuous basis पे है, और continuous basis पर ही होगा because एक बाकायदा protein gene की mutation है ना, तो continuous basis पर ही होगा. Autoimmune pancreatitis is pathogenically distinct from the chronic pancreatitis that is associated with presence of IG4 secreting plasma cells in the pancreas. So इसकी पूरी etiology different है autoimmune pancreatitis की, that we will discuss separately. As many as 40% of the individuals with chronic pancreatitis have no recognizable predisposing factors. So that's an interesting thing. If you don't know what is causing it in about half of the patients, that's a difficult thing to then diagnose, and there we label them as idiopathic. But anyways, we try to look for the genetic mutations such as CFTR gene mutation, yes, PINK1 gene mutation, and recent studies have also correlated CPA1 and cell protein gene mutations associated with chronic pancreatitis. But you see, most of them unknown. खैर ज़्यादातर जो आपको बात याद रखने वाली है ना, वो ये कि the most common cause of chronic pancreatitis is alcohol consumption. So remember alcohol, and even if you forget the rest, then everything is fine. Now, what is the pathogenesis? Although the pathogenesis of chronic pancreatitis is not very well defined, it is actually understood कि it's a mix of repeated acute pancreatitis. तो बार-बार acute pancreatitis से जो damage हो रहा है, उससे फिर it leads to chronic all the features such as increased fibrosis and loss of tissue and all those sort of things जो chronic sort of disease में होती है. इसकी pathogenesis के कुछ जो important points हैं, जो hypothesis हैं, वो ये है. Ductal obstruction by concretion. So alcohol की वजह से मैंने आपको बताया thick protein discharge होता है in the secretions. They may cause plaque formation and ductal obstruction. Very very routine ductal obstruction will lead to pancreatitis. Toxic metabolic effect theory क्या है? Toxins including alcohol and its metabolites can exert direct toxic effect. ये आप नोट कर रहे हैं, ये दोनों चीज़ें exactly same pathogenesis है जो हमने बात की थी acute pancreatitis में. Oxidative stress, alcohol increases the oxidative stress, increases the inflammation, pro-inflammatory cytokines and chemokines, and that leads to, because of the reactive oxygen species, there is damage of the acinar cells. Inappropriate activation of pancreatic enzyme is also supposed. So these are the theories. Basically, alcohol is causing all these things, and all these things we just also studies in acute pancreatitis. So pathogenesis kind of remains the same. अगर आप मेरा general formula याद रखेंगे, then your life will be easy. कि जो acute pancreatitis है, that basically leads to chronic pancreatitis अगर ये बार बार repeated हो रहा हो और आप प्राइमरी कॉज को ख़त्म नहीं कर रहे हैं. यानी if somebody is consuming a lot of alcohol very very frequently और अल्कोहल कंजम्पशन की वजह से सपोज उसको एक्यूट पैंक्रेटाइटिस हो रहा है, तो बेसिकली आपको उस कॉज को ख़त्म करना है ना. यू हैव टू स्टॉप अल्कोहल कंजम्पशन, लेकिन वो बंदा नहीं ख़त्म कर रहा है अल्कोहल के यूजेज. तो इवन अगर एक्यूट इन्फ्लेमेशन ख़त्म भी हो जाती है जो उसका एपिसोड है, लेकिन अल्कोहल कंजम्पशन नहीं ख़त्म होती, तो क्रॉनिक पैंक्रेटाइटिस कैरी ऑन हो सकती है. Okay. In contrast to acute pancreatitis, a variety of fibrogenic cytokines, fibrogenic cytokine, ये बड़ा important word है, pro-fibrogenic, because they will cause fibrosis, such as TGF beta, because chronic inflammation का एक hallmark है कि there is ultimately, fibrosis, and once fibrosis happen, this indicates that the pancreas is basically being destroyed. Okay. Normal cellular architecture जो है, it is being replaced by fibrosis. Then there is acinar loss, obviously because of parenchymal fibrosis, so normal cells are lost and fibrosis takes over. Some clinical features, they are manifested not as acute pain, but there is repeated bouts of pain and jaundice. Jaundice is because of obstruction, if there is any of the bile duct, and that will lead to regurgitation of bile. There will be indigestion issues, persistent or recurrent abdominal and back pain. So they are kind of vague pain type of symptoms, but they are persistent for very very long time, and acute attacks can exacerbate the chronic condition. So sudden serious acute abdomen can also happen. Okay. Right. So if we carry on the discussion, the diagnosis of the chronic pancreatitis requires a high degree of clinical suspicion. During an attack of abdominal pain, there may be mild fever, modest elevation of serum amylase. This will distinguish it from acute pancreatitis, जहाँ पे amylase के high levels होते हैं. In end-stage disease, however, acinar destruction may be so advanced that enzyme elevations are actually absent. Because enzyme तब release होंगे ना blood में जब acinar होंगे, लेकिन chronic inflammation है, acinar already बिल्कुल वो कहते हैं ना टुक चुके होंगे, बेड़ा गर्क हो चुका, acinar है ही नहीं, तो enzyme कहाँ से निकलेगा? So do not rely on the enzymatic laboratory values. Gallstone-induced obstruction may manifest as jaundice if there are gallstone and obstruction of the CBD. if you see on CT scan, you may see calcifications or fibrotic changes in the pancreas. So the diagnosis is pretty much clinical correlation of the symptoms and then the history and then the laboratory findings. Although chronic pancreatitis is usually not acutely life-threatening, the long-term outlook is very, very poor because आपके pancreas में fibrosis हो रही है, and fibrosis is not a good news. It's a very, very bad news. The most common long-term sequelae of chronic pancreatitis is insufficiency of the pancreatic exocrine enzymes. और अगर वो enzymes नहीं बनेंगे तो there will be obviously malabsorption of fat, malabsorption of fat-soluble vitamins. तो all sort of metabolic issues आपकी body में start हो जाएंगे. Pain, pancreatic pseudocyst also happen. So these are all the things that we have already done. So now after the inflammation story, we have to deal with the pancreatic tumors, neoplasms. So pancreatic exocrine neoplasms can be cystic neoplasms or solid tumors. Cystic neoplasms means they will have these cyst-like structures, and solid will be, solid mass of cells. Some tumors are benign and some are obviously malignant. So let's start our discussion with the cystic neoplasm. They are diverse tumors that range from harmless benign cyst to invasive, potentially lethal cystic cancers. Approximately 5% to 15% of the all pancreatic cysts are neoplastic, which means majority of them are benign. These constitute less than 5% of all pancreatic neoplasm. Some of these are almost always benign. Okay, others such as mucinous cyst neoplasms can be benign as well as malignant. So they can be benign, malignant obviously कम होते हैं, benign ज़्यादा होते हैं. Serous cyst adenomas account for approximately 25% of all the pancreatic cystic neoplasm. So that's the most common cystic neoplasm. They are composed of glycogen-rich cuboidal cells surrounding a small cyst. So there will be a small cyst and cuboidal cells surrounding the cyst. अगर कोई cyst हो और उसमें कोई epithelium ना हो, then we call it pseudocyst. ठीक है, ये बात मैंने भी ऊपर आपको समझाई थी. The tumors typically manifest in the 7th decade of life. So it's a tumor of late old age, and there is a female to male preponderance of 2:1. These tumors are almost uniformly benign. Surgical resection is curative in vast majority of patients. Now, most serous tumors, जो कि cyst adenoma category के हैं, they carry a mutation, loss of function mutation in the von Hippel-Lindau gene, which is a tumor suppressor gene. So this tumor suppressor gene is not working, so there are more chances of tumor. Okay, and which you will recall is a negative regulator of the HIF1 alpha. So mutation in the VHL gene and then the regulator HIF1 alpha is all disturbed, leading to formation of cyst adenomas. In contrast to the serous cystic tumors, close to 95% of the mucinous cystic neoplasms arise in women, usually in the body or tail of the pancreas, and manifest as painless, slow-growing masses. The cystic spaces are filled with thick, tenacious mucin. The cysts are lined by the columnar epithelium here. Based on the degree of cytologic and architectural atypia in the epithelial lining, non-invasive mucinous cystic neoplasms are classified as either low-grade, moderate, or severe dysplasia. Up to 1/3 of these cysts can be associated with an invasive adenocarcinoma. So all these details, even if you want to remember, if you don't want to remember, that's fine. The bottom line is that the thing that you should know is, you see these are cysts. So if you have cystic issue, that is cystic neoplasm. If solid mass of cell, it is solid malignancy. Amongst the cystic, serous cyst adenocarcinoma, cyst adenoma is the most common one. They can be benign, they can be malignant. Okay. Then the next category is the intraductal papillary mucinous neoplasm. So intraductal is within the ducts, obviously. In contrast to the mucinous cystic neoplasm, the intraductal papillary mucinous neoplasms occur more frequently in men. So here is a gender difference between the two tumor types than in women. These tumors arise in the main pancreatic duct. इसीलिए इनका नाम intraductal tumor है. Okay. As with the mucinous cystic neoplasm, the epithelia of these tumors harbor various grades of dysplasia. It can be mild, moderate, severe. In particular, colloid carcinomas of the pancreas, which are adenocarcinomas associated with abundant extracellular mucin production, nearly all, इनके बारे में अभी पढ़ेंगे हम, nearly always represent malignant transformation of these tumors. Up to 2/3 of these tumors harbor oncogenic mutation of gene S present on it. If you can remember these details, well and good for you. So these tumors arise within the duct. ठीक है, अब बात करते हैं कार्सिनोमा की. So that's the solid malignancy. So solid malignancy is the pancreatic carcinoma, and it's basically adenocarcinoma because pancreas is a gland, and you know that if there is a gland that we are talking about, it's adenocarcinoma, and it is a major cause of death. So it's a very high mortality tumor. Okay, you see is the third leading cause. Actually ये recent numbers नहीं है. If you want to study the recent most numbers, you must follow GloboCan. Okay, GloboCan is the cancer repository website जहाँ आपको latest numbers मिलेंगे. Now close to 49,000 Americans were diagnosed with the pancreatic cancer. It's just telling you that how common and how lethal it is. Pathogenesis, like all the cancers, pancreatic cancers arise as a consequence of inherited or acquired mutations, obviously. जैसे cancer की pathogenesis होती है. So there are accumulating, mutation profile. Okay. Now, in a pattern analogous to that seen in the multi-step progression of the colon cancer, वो हमने देखा था normal से फिर एक mutation, फिर दूसरी mutation, and it leads to polyp formation and then cancer formation. There is also progressive accumulation of genetic changes in the pancreatic tumors, which leads from normal to preneoplastic to neoplastic cancer. While both intraductal papillary mucinous neoplasm and mucinous cystic neoplasm, जो भी ऊपर हमने किए थे, can progress to invasive adenocarcinoma, the most common antecedent lesion of pancreatic cancer arise in small ducts and ductules. So it's not the main duct, it's usually the small ducts and ductules, and they are called pancreatic intraepithelial neoplasias, PANCREAS जिसको हम नाम देते हैं, pancreatic intraepithelial neoplasias. These are the names for adenocarcinoma arising in the small ducts. Evidence in favor of the precursor lesion of the PANCREAS to frank malignancy include observation that these microscopic lesions often are found adjacent to the infiltrating carcinomas, and the two share a number of genetic alterations. The recent sequencing of pancreatic cancer genome has confirmed at 4 genes, at least. There are more genes as well, जो इनकी mutations associated. They are KRAS, CDKN2A, and P16, SMAT4, and TP53. KRAS is the most frequently altered oncogene in the pancreatic cancer. It is activated by a point mutation in greater than 90% of the cases. So KRAS, आपको ये नाम याद रखना है. So that's the basic point. ठीक है. इसी तरह P16 जिसका दूसरा नाम CDKN2A है, it is another very frequently mutated gene. So that basically आपसे जो एग्जाम में पूछा जाएगा, names of the genes which are usually mutated in pancreatic cancer development. So this is one of them as well. And P16 is, by the way, a tumor suppressor gene. So if a tumor suppressor gene is not working, tumor is not suppressed and tumor happens. SMAT4 is another tumor suppressor gene which is mutated, and then TP53 is the world famous tumor suppressor gene hai. So if you look at the diagram here, that is showing you the consequence kis tarah se develop. So that's the normal epithelium of the small ductule. Obviously you see these cuboidal epithelium. Then this is the development of the story. Panin developing. Remember what was panin? Go back to your discussion of pancreatic intraepithelial neoplasia. So intraepithelial neoplasia is kind of happening here. जैसे cervical intraepithelial neoplasia था sin, बिल्कुल ऐसे ही pancreatic intraepithelial neoplasia. And then they are accumulating mutations such as KRAS. You see, inactivation of P16, inactivation of these tumor suppressors. So tumor suppressors जाते जा रहे हैं, and the cancer is forming. Once the tumor suppressors are all gone, there is accumulation of these mutations, and then there is frank invasive carcinoma. So there is a sequence of events that you actually should remember. It begins with penin, the pancreatic intraepithelial, intraductal, intraepithelial is the word that we use actually. That's of the small ductule. This epithelium is from the small ducts, but this is pancreatic intraepithelial neoplasia. And then through the accumulation of various, inhibitions of tumor suppressor genes, this is what you get, the invasive cancer. Okay. So, some people are now also associating BRCA genes, which are already very well established in breast cancer, stomach cancer, also now in the pancreatic cancers. Pancreatic cancer is primarily a disease of older adults, 60 to 80 years of age. The strongest environmental influence is smoking, which doubles the risk. Long-standing chronic pancreatitis is also a risk factor. The two entities have a bidirectional link with the pancreatic cancer. Thus, for example, tumor arising in the head of the pancreas often causes chronic pancreatitis in the distal parenchyma, while diabetes caused by duct obstruction and subsequent pancreatitis may be manifested by the underlying neoplasm. So, it's kind of a thing कि inflammation की वजह से chronic pancreatitis और cancer हो सकता है, और cancer की वजह से भी inflammation हो सकती है. It's kind of philosophical debate. In fact, approximately 1% of the older adult population with a new onset diabetes harbor unsuspected pancreatic cancer as well. Okay. Familial clustering of pancreatic cancer has been reported, and a growing number of inherited genetic factors are now recognized that increase the risk of the cancer, and BRCA2 is one of them. So familiarity, जैसे breast cancer में established है, ऐसे is now being also established in pancreatic cancers. Clinical features will be carcinoma of the pancreas typically remains silent until there are severe symptoms such as obstructive jaundice. अभी मैंने पूरी इसकी theory बताई है कि this is the pancreatic duct, for example, this is the common bile duct, and they combine together to enter into the duodenum. If there is the head of pancreas cancer and it blocks this area, the main entrance point, it will lead to obstructive jaundice. So it may develop. There may be generalized symptoms of cancer such as anorexia, generalized malaise, cachexia, cancer issues, also migratory thrombophlebitis. It can occur in some of the patients because elaboration of the platelet aggregation happens, procoagulant activation, because pancreatic tumor के degradation products से जो products release होते हैं into the blood, they activates the procoagulants and there is platelet aggregation. Okay, and that leads to अगर ये veins में blockage हो रहा है, so that will be thrombophlebitis. As previously stated, the new onset diabetes is sometimes the first manifestation of the pancreatic cancer. So pancreatic cancer patient may come to you with obstructive jaundice. In very old patients, सारी जिंदगी diabetes नहीं हुआ, 80 साल की उम्र में पहली दफा आ रहा है मुझे diabetes हुआ है. So think about cancer developing in the background. The clinical course of pancreatic carcinoma is rapidly progressive. अब ये point ये है कि एक दफ़ा जब पता चलता है तो उसके बाद already time बहुत कम होता है patient के पास. So ये उसकी वजह ये because ये काफ़ी अरसे से develop हो रहा होता है. So it is taking a lot of time to manifest to the clinics. But once to the clinic, it is very rapidly progressive. So high mortality tumor, death फौरन हो जाती है. Although serum levels of many enzymes are known to be as biomarkers such as 19.9, that is one of the commonly used marker which is very much elevated in pancreatic cancer, it's not very highly sensitive. So if it's there, it means something. If it's not there, it may not mean something. So we do not have exact diagnostic approach for any biomarker. But this is the one which is commonly used. Okay. Several imaging techniques have been used, particularly CT scans, because ये सिर्फ cancer की extent नहीं बल्कि उसकी if you want to do the staging, clinical staging of the cancer, so if the cancer has metastasized to bones, for example, or brain or any other part of the body, you need to do CT scan. So they are all helpful, diagnostic techniques. So that's all about the pathology of pancreas. I hope you liked the video. If you did, please subscribe the channel, share the video with your colleagues, and I will see you next very soon with another video. So take care of yourself.